let's discuss infective endocarditis. Infective endocarditis is caused by microbial infection within the endothelium of the heart and is generally bacterial. It was previously called bacterial endocarditis. Vegetations form and adhere to the endothelial structures. The heart valves are most often affected. Septal defect, chordinae tendineae, or mural endocardium may also be infected. And again, most cases are bacterial, but there are an increasing number of infective endocarditis that are caused by fungal, chlamydial, or rickettsial organisms. So what kind or types are there? There's acute and subacute and chronic. Acute is a fulminant process. Death can occur within days to less than 6 weeks. And look at those organisms, ones we are familiar with: Staphylococcus aureus, Streptococcus pyogenes, Streptococcus pneumoniae, and Neisseria gonorrhea. The subacute, death occurs within 6 weeks to 3 months, and then that chronic infective endocarditis, death happens after 3 months. Subacute and chronic infective endocarditis have a more subtle, indolent course, and the usual causative organisms are viridans streptococci. Causes of infective endocarditis do include a native valve infection, a prosthetic valve endocarditis, endocarditis in injection drug users, healthcare-associated endocarditis, cardiac implantable device, and endocarditis. So generally, the clinical presentation early in the infection is generalized fatigue, malaise, night sweats, chills, weight loss, weakness, nausea and vomiting, and anorexia. I did make a note that with Staphylococcus aureus infection, there's typically an abrupt onset that prompts the patient to seek early medical attention. So when that's the causative pathogen, it's a different course, much more abrupt, and they come into your office sooner. Physical exam, the onset of symptoms can be days to weeks. Initially, they're kind of non-specific for some people, unless, as I said previously, the cause would be S. aureus. So early symptoms: fatigue, malaise, night sweat, chills, weight loss, weakness, nausea and vomiting, and anorexia. However, that highly pathogenic cause may cause abrupt symptoms. Again, that's just a repeat of the last slide. Just be aware of that. Fever is present in the majority of patients, but might be absent in older adults. The neurologic findings: there's evidence of cerebral emboli in approximately 20 to 30% of the people with infective endocarditis. Ophthalmologic findings: really Roth spots can be identified, which are edematous hemorrhagic lesions of the retina. Cardiac, the signs and symptoms of infective carditis vary to causative organisms and the degree of systemic involvement. So you just have to keep that in mind as you're assessing. Pulmonary embolism is the most often associated with tricuspid valve endocarditis in injection drug users. So that ought to up your differential when you're seeing someone with a known history. Splenic and dermatologic findings are interesting related to infective carditis. Splenomegaly has declined significantly, with rates reported at approximately 11%. But possibly because of increasing acute infective endocarditis or a shorter time to diagnoses. The dermatologic findings often reveal petechiae on the conjunctiva, the palate, the buccal mucosa, and the extremities. They're really present about 20 to 40% of the patients, and usually for the first few days of the infection. One nuance is Janeway lesions and Osler nodes. Those are cutaneous lesions associated with endocarditis. Janeway lesions are non-tender hemorrhagic macules. They're about 1 to 4 millimeter on the palms and soles, and they result from septic embolism. Osler nodes are painful nodes on the fingers and toe pads that last hours to days. And that's just a kind of a nuance of the dermatologic presentation that you might find on exam. Diagnostically, 3 blood cultures for different venipuncture sites are imperative to obtain. CBC with differential, RA latex, ESR, which you know is a nonspecific inflammatory marker, circulating immune complexes, serum complement, renal. A chest x-ray is a really important piece of our diagnostic tools, ECG, and an echocardiogram. I don't expect you to know all of the differential diagnoses, but I do want you to look at that Duke criteria on page 589 to determine specific types of infective endocarditis. And you can just look through this list of differentials. I think it's important for us not to miss that acute rheumatic fever, atrial myxoma, lymphoma. Management, it is what we need to know is that specialist consultation and immediate referral to the emergency department are both indicated for patients presenting with fever and suspicion of infective endocarditis. What happens after that is generally antibiotics based on culture and sensitivity. And if you note in that chapter, oh my goodness, they gave us every antibiotic listed over about 4 pages. You don't have to know that. Just realize that the antibiotics are specific to the culture and sensitivity, and they're certainly specific to what type of infective endocarditis. Repeat blood cultures post-treatment and management with specialists. Primary prevention, infective endocarditis prophylaxis for high-risk individuals. Referral, again, immediate consultation, hospitalization are warranted if a history, symptoms, and clinical symptoms of infective endocarditis present. And the most imperative things that are generally obtained are those blood cultures and an echocardiogram immediately. Patient education and health promotion is a huge part of what we should do for our patients, educating them on the etiology and the treatment of infective endocarditis. So important for us to be able to understand and use evidence-based for preventative therapy. And there has got to be an emphasis on dental health, since that is the #1 causation of infective endocarditis. And then patients need to understand the risk of relapse with this infection and the signs and symptoms to watch for. I liked this illustration on this last slide. It's pretty basic, but it's really true. It includes preventive strategies, improving the diagnosis, and optimal management. And it's just for FYI. Thank you.